guys had a wonderful day yesterday. I put some EKGs up here for you guys. Some of the stuff we reviewed already, some of it isn't, we haven't. But I encourage you, I've gotten the diagnosis, or at least what the machine reads out. And if there's any changes, someone will have made a little mark here, a little note to the side. So I encourage you to read these and then flip it over and see if you're familiar with. So, do the basic stuff that we looked at already, the rate and the rhythm, and then we'll talk about, if there's a couple of tachycardic rates in there to figure out what those are. Obviously, it's not something to be tested on, but just to kind of give you an idea of what you might be seeing in some of the ECG. So yesterday was Mother's Day. My kids got me a picture of themselves with their thumbprints I made out of heart. It was so sweet. And we had fish and steamed vegetables. So that steamed vegetables made me think of a joke. So what do you call an angry carrot? A steamed veggie.
Wow. We got to get one of these.
Okay, so we're going to talk about part 2 of rhythms. Now we're going to start with bradycardic rhythms, but then there's other rhythm abnormalities you need to be familiar with as well. We'll talk about ectopic rhythms, we're going to talk about premature beats, we're going to talk about ectopic beats, and then a couple of other things as well. Now let's do a quick skills check. Let's see here. Banks. James Banks. Where you at? Okay, sir. What do you think here? Let's go with what is our rate, and what do you think the rhythm is?
About 180 now.
180?
Yes.
And how are you doing that? What
I'm
method?
doing 10-second strips, so there's
18, and we times it by?
10, or 6, sorry.
6. So about 106. So tachycardic, okay? So then we got to go through our, is it narrow or is it wide?
It's narrow.
Narrow. Is it regular or is it irregular?
There might be a couple beats that might be faster.
Looks a little irregular, so we'll go with that. So irregular, narrow, so what are our options? Atrial fibrillation, multifocal atrial tachycardia, a flutter with a variable block. What do you think's going on, sir?
Multifocal.
Multifocal atrial tachycardia. Because look at those P waves. Those P waves, we see a P wave, we see lots of different P waves, but that's the key, is different. There's a P wave here, and although these two look similar, it definitely doesn't look like that one. It doesn't look like that one. So the P waves are there. We've got inverted P waves here. So 3 are different morphology P waves in an irregular, narrow complex tachycardia, multifocal atrial tachycardia. These patients will typically come in acutely short of breath, maybe a COPD exacerbation. They may have a history of severe lung disease. They may have a pulmonary embolism. What's bringing them in is not the fact that their EKG is abnormal, it's their signs and symptoms. Respiratory signs and symptoms are associated with this. Okay, and what about this one? Anthony Reed. What do we think is going on here?
Well, it's tacky. They're the opposite there.
Why?
It's 140-ish.
So wide complex, is it regular or irregular?
It's
Regular, wide complex, regular, what are our options? V-tac or V-flutter? V-tac, right? Because V-flutter You know, we're 300s. And how is that patient going to present in V-flutter? Probably not good. Probably not good. This person might be talking to you for a little bit. But V-flutter, they're probably going to be unconscious. Okay? So this is ventricular tachycardia. The rate is fast, but slower than we're going to see in V-flutter. All right, we've got another one here. Ramos, David Ramos. Okay, sir. This is going to be a little bit, it's not difficult, but it's not considered, it's not tachycardic rate. But what is it? So it's narrow and irregular. What do you think is going on? Look at lead 3. Look at lead 3. What do you see in lead 3? Well, that's a good observation, but what you see is, I don't know what I see. Because is that a U? Is that a T? Is that a P? And so when we see something like that, we're like, what the heck? What do we call those? Fibrillatory waves. We're not sure what it is. We do think we see a T. We're not, is that a U? We're not really sure, but they're fibrillatory waves. So this is actually atrial fibrillation, but not with a fast rate. So this patient's probably on some sort of medication to control their rate, but they keep them in atrial fibrillation. And that's okay. There's a lot of people that walk around with atrial fibrillation. They have a controlled rate. They put them on usually a beta blocker to control their rate, and then they will put them on some sort of blood thinner, some sort of DOAC to help prevent them from having a stroke. And keep them in atrial fibrillation unless the patient doesn't want, and then they can offer them some sort of intervention. Yes?
And because we talked about preload, backload, contractility and stuff, are these patients going to have like low blood pressure? Not necessarily.
Well, they will typically have a little bit lower because of the meds that they're on. Okay. Otherwise, their blood pressure, if they weren't on meds, their blood pressure is often fine, as long as they have not been tachycardic for too long. So if they're older and they already have some cardiac issues, it doesn't take long for their blood pressure to bottom out because they don't have enough circulatory volume. This is atrial fibrillation. Then this is our last one. Derek Mask. Okay, sir, what do you think's going on here?
So there's like the normal, I'm going to fuck all the word again, so apologies, but I guess the normal, would you call it rate? Rate?
Okay, yeah.
And then it's the variable P wave, whatever. There's a 5-to-1, I think it's a 4-to-1, and a 3.
Yes, yeah. So we got an irregular rhythm. So irregular rhythm, we think about our irregular rhythms, AFib, A-flutter with variable block, multifocal tachycardia. So what we can see here, and this is one of those memorizations, is we can see these waves that look like something we want to go to Hawaii and ride, right? So they look like they're nice, kind of, outside there are U waves, you might say, what we call these flutter waves, right? So we would call this what? Atrial flutter with a variable block. Atrial flutter with a variable block, and that atrial rate is going to be 300 to 400 on that atrial rate that's associated with that.
Question, Matt?
Yes.
For that slide, the previous one, would you consider that those delta waves kind of like where the QRS complexes are at?
Here?
Yeah, all of them almost have it, almost kind of like resembling WPW almost.
You know, you wouldn't be wrong if you were like, man, I'm really concerned that might be a delta wave, but it certainly comes up and comes over on the majority of these. So it's possible. It is possible. We'd have to see what their underlying issue is. It's hard with atrial flutter because sometimes that will happen, but certainly that's something good to point out that you do look like. We haven't really talked about that. We'll talk about that either today or tomorrow. But these QRS complexes should go straight up and straight down. We can see we have a little bit of it convex here, then goes concave, and then here it's convex and it's concave. Yeah. Okay, and then we've got, what about Hennessy? Gordon Hennessy. Okay, sir. 75-year-old comes in, he has a history of 50-pack, year history of smoking, family history of CAD, diabetes, hypertension, he's got acute arrhythmia, cough, and wheezing. This is the EKG. What do you think's going on, sir? E, multifocal atrial tachycardia. That. Nobody agree?
Yes.
Especially with that history. Comes in, okay, big smoking history. Big smoking history. Okay, he's got cough, wheezing, so that's his respiratory signs and symptoms. So this might be something similar to the stem that you will see. You see there I put a family history of blah, blah, blah. Well, that's exactly what that is, blah, blah, blah. Right, that's fluff stuff. That's what we do to make these stems longer. But you've got to figure out first, okay, which of the following best describes the underlying rhythm? That's my question. Let me look at the answers and then let me go back to the question and see what the history of this patient is. Because otherwise, you may read that entire thing and then the question is, what is the rate? And in your mind, you're like, oh man, that's multifocal atrial tachycardia. This guy's got shortness of breath, he's got wheezing. And then the question is the rate. And you're like, oh man, I just wasted all that rainbow. So make sure that as you're going into this exam, that you understand what the answers are, and then figure out what the question is asking. All right, and then we've got this last one. If we look over here, what is this showing us? Atrial fibrillation, right? Atrial fibrillation. Got all these fibrillatory waves. And a flutter, if this was a flutter, why can't it be a flutter? Well, we don't really have those good flutter waves, and it's very irregular, and it's not even irregular to the point where you see flutter waves that tell you this is a variable flux. It's atrial fibrillation. Okay, Florence Nightingale was born on this date in history. She was a French nurse, I believe, French nurse. And really, she did what I think, if we look at her history, and I don't know a significant amount of her, but she really made what our current day nurses are today. You know, she served as a big trainer of nurses in France in the Crimean War, and she brought about, sanitary conditions back in the 1820s. That's pretty important, and because of her, today is considered International Nurses Day. Okay? Yeah. And then 1907, Katharine Hepburn. I think the majority of people probably don't know Katharine Hepburn, but certainly she was in movies up until, the 1990s. I think is when she was in. She was a really good actress. Okay, let's act this fact or fiction. Van Tassel, Kenneth Van Tassel, where are you? Okay, sir. If you bring in a burn, you should encourage your patients to apply ice to that affected area. False. Why? Any idea? Yeah, potentially increasing the damage, because if we apply, here you go, sir. If we apply ice to an already damaged epidermis, okay, we're decreasing the blood supply, and although that makes a patient feel good for a second, it actually causes an increase in damage. So what do we want them to do? Butter? Mayonnaise? No, that holds the heat in. Cool water, just running underwater. Because lots of patients will grab something, they'll burn their fingers or burn something like, oh my God, I better come in and see you. Just cool water, that's the best way to do it. No ice, no butter, no mayonnaise. All right. We're going to continue on with our deliberate approach to reading these ECGs. We've already talked about the rate. We're still in our rhythm component. Okay, we know part of the rhythm was you're trying to figure out if it's fast, and now we got to figure out if it's slow. So we still want to figure out, is this right, what the rate is it regular or irregular? Look at our QRS intervals, are they wide or narrow? Look at our ST segments, are they elevated or depressed? And our T waves as well. Okay, and then we want to know, is there a P before each QRS complex and a QRS complex after each P wave? Look at our PR intervals. That's going to tell us about if there's a block at the junctional area, the AV area. And then we're going to look at our QT intervals as well. Brady arrhythmias, rates less than 60. And for those rates, we're going to use to determine the rate, we're going to use the 10-second method or the 6-second method. The counting method only goes down to 60. So if it's less than that, we don't use that. You can have a sinus bradycardia where it is coming from the SA node. We're going to look at lead 2, we're going to look at like AVR, upright P and 2, inverted P and AVR. It could be going from the junctional area. Remember, the junctional area is going to be around the AV node. So AV node bundle of this. Could be coming from the ventricular area. Ventricular is really primarily going to be those Purkinje fibers. They do have pacemaker function now. Or we could have some sort of heart block that might be causing our bradyarrhythmia. Okay. So we can have decrease in automaticity. We talked about automaticity. We talked about the decrease. We have the sympathetic and we have parasympathetic. So if something is affecting the parasympathetic system, that's going to decrease our heart rate. You might have somebody that has increased vagal tone. There are people that are super, super sensitive to their vagus nerve. They go from sitting to standing, and they're going to pass out. Or they get really anxious and they pass out. Okay? Or this might be something that's normal in someone that runs a lot. Their heart is conditioned to beat at a slower rate. If someone has an inferior wall MI, it'll knock out their right coronary artery, which will knock out their SA node. SA node is not going to be able to fire appropriately. And sometimes it's from medications that we prescribe our patients. Okay, so we had a patient last week come into BMC who was on Cinvyx PCM, and they had a higher hemoglobin A1C, so they put him on a diabetic. Right? So and then he comes back to see them for routine labs, and he's got glucose in his urine. So they're like, oh my God, you've got to go to the emergency department. So, and they actually did a blood glucose, and it was like 90. But he's got glucose in his urine, so they sent him to the emergency department. Well, that's how the medicine works, that you put him on. You put him on that medicine gets rid of the glucose by putting glucose in the urine, he pees it out. So they send him to the ER without even knowing the medication that they put him on. Right? So sometimes we will put these patients on beta blockers, calcium channel blockers. And those medications do what? Slow the heart rate. Okay? So know the side effects of your medications, or even the normal parts of the medication. Something like adenosine. Adenosine is not designed to slow the heart rate. We give people that have a supraventricular tachycardia, we give them adenosine to slow their heart rate down so we can figure out what's going on and ultimately try to get them out of that SVT. It could be a metabolic, or either like hypothermia or even hypothyroid. Okay? Hypothyroid, mixed edema coma. These patients with mixed edema coma can come in, or just mixed edema can come in with heart rates in the 20s and 30s and not coming specifically from the ventricle. Electrolyte derangement, so primarily hyperkalemia with lots of electrolyte derangements can cause bradycardia. And then anything that causes increased intracranial pressure, like a stroke or an intracranial mass, that's going to affect the parasympathetic system, and that can cause bradycardia. In Lyme's disease, what can Lyme's do? Do you guys learn about Lyme's and infectious disease already? No? Because Lyme's disease can cause a myocarditis. So it can affect the heart, and that ultimately can cause bradycardia. That's treated with, anybody know? Losefin. So how might these patients present? Well, they could be asymptomatic. They could be lightheaded, dizzy, feel like they're going to pass out, or they could have passed out. And you might have altered mental states, especially in an older patient whose heart rate is 20 or 30, then they certainly might have altered mental states. Anybody who has a heart rate of 20 or 30 might have altered mental states. So if sinus bradycardia, and this is going to be considered a kind of a normal bradycardia, we're going to look for our PQRS, or lead 2, we're going to look for the upright P, and then in AVR, we'll look for that downgoing P. So we've got an upright P here, we've got a downgoing P here. We look at our rate here, 1, 2, 3, 4, 5, 6, 7, 8. 8 times 6 is 48. So this is a bradycardic rate, but it's sinus bradycardia because we have P, QRST, P, QRST, and we've got that down going, right? Okay, so what do we do about that? Nothing. They have sinus bradycardia. There's really nothing to do about it. Okay, sometimes we can get an escape rhythm. We know that the SA node is our primary pacemaker, but if the SA node does not fire, then somewhere else in the heart is going to fire. Usually the atria first, and then the junctional area, and then the ventricular area. And so what can cause this SA node suppression? Lots of things. Again, we talked about myocardial infarction, especially if their right coronary artery is involved. Rheumatic heart disease, sarcoidosis can cause. Someone goes into respiratory failure or they're having significant respiratory compromise. Metabolic drainage like hyperkalemia can cause it, and then again, medications. Some of these patients might have symptoms of that, like dizziness, lightheadedness, and feel like they're going to pass out. Right? If it's significantly low with their heart rate, these patients may have hypotension, and they again may have passed out. That's what brought them in to see you. So once the SA node fails, we know we go to the atria, but I'm going to hold off talking about the atrial focus for a minute because that's typically not a bradycardic rate. The junctional area is typically a bradycardic rate, and the rate is typically 40 to 60 beats per minute. Okay? You can have just a junctional rhythm, like we see here at the bottom, or you can have something called a junctional escape rhythm. And what that is you have a PQRST that comes all the way through, looks pretty regular, and then you have this pause. And that pause is just enough for the heart to say, well, wait a minute, what's going on? Something else needs to fire. And if the atria don't fire, then the junction area is going to immediately take over. You do the overdrive suppression. The junction area realizes there's no pacemaking responsibility that's currently occurring, and so it's going to take over that pacemaking responsibility. In order for it to be called an escape rhythm, you need to have 3 or more beats for that to be considered a rhythm. And sometimes you can have 3 or 4 or 5 beats of that escape rhythm, whether it be junctional or ventricular, and then the SA node starts to fire again, and it takes over pacemaking responsibility. And what you'll see is a change, and not necessarily your QRS complex for junctional, but you'll see your P wave, no P wave, no P wave. Okay? Or if you do have a P wave, it's going to look inverted. Okay, so we have our PQRST, we've got this pause here, and then we've got our QRS complex, which tells us the ventricles are depolarizing, but we do not have a P wave here. We don't have a P wave here. Okay, so this is coming from the junction area. Oftentimes with a junctional rhythm, or even a junctional escape beat, or premature junctional contraction, the QRS complex is really, really narrow, so maybe like a box or so. We know that we have a wide complex QRS and a narrow, but this seems to be super narrow a lot of times associated with those junctionals. So again, because of where that depolarization or that pacemaker responsibility is taking place around that AV node, you might get some retrograde depolarization of the atria. So if we have directly at the AV node, that is taking over pacemaking responsibility, it's going to depolarize a little bit back up into the atria, and so that may be seen on the ECG as an inverted P wave. Not an upright, but you may see an inverted. So you either see no P wave at all, or an inverted P wave that would tell you this is coming from the junctional focus. Okay, so here we have our P, but it's inverted here, and we go QRST. We've got an inverted P here. This is interesting here because our P wave, we can see our QRS comes up, down, and then there's a little bit of a hump at the bottom, and our P wave is inverted in there. And then this one actually has a P wave after. Okay, but the majority of what you're going to see is this top one, inverted P wave or no P wave at all.
Yeah.
Yes?
Can you explain why you would see the P wave before the QRS if the junction's firing and you're getting ventricular depolarization? Or is it fires and then it's closer to the atria, so the atria is...
So can I explain why you see the P wave before the QRS?
Yes, sir.
Yeah, so your depolarization is coming from right here, right at the AV node. And that AV node, because the depolarization there is so slow, it'll put some slight depolarization back up towards the atrial. So that's why you can see that before the QRS. Now, why are we seeing after or within the QRS the same exact reason? Because of that slow depolarization. Or instead of the AV node depolarizing, we're down at the bundle of His. And the bundle of His can still come back up in retrograde, but it's going to take a little bit longer for that depolarization to hit our ECG machine. So this is a junctional rhythm. It's not an escape rhythm because we didn't start with a different rhythm and then go into the junctional. This is just a junctional rhythm. So we have our QRST, but we can see we have no P, no P, no P. None of these have a P wave in front of them. Okay, so this is a junctional rhythm. And then our rate here, we have 9 R waves across. So 9 times 6 is 54. Okay, so 40 to 60, remember, is typically our rate. And we're not gonna hold our feet to fire on those rates because sometimes it's gonna be a little bit higher, sometimes it's gonna be a little bit lower. You can get junctional rates of 100. Okay, they're accelerated junctional rates. But in general, we think about a junctional like a 40 to 60 rate. We're just looking to see, do I have a P wave or not? Do I have a P wave? P wave? If I don't have a P wave, that's telling you that's coming, and I have a narrow complex, that's coming from the junctional, regardless of the rate, that's coming from the junctional somewhere. Okay, you can get a ventricular rhythm. Again, that's a node fails to fire. We don't have the atria that's involved. We don't have junctional area is not firing either. Now we're down to our Purkinje fibers. We're down to the last part of our heart that will help our heart fire, help our heart pace our heart. Okay. And because of how the ventricles are depolarized, our QRS complexes are going to look a little bit different. They're going to be wide because instead of ventricles being depolarized via the electrical conduction pathway, okay, they are now depolarized myocyte to myocyte. Purkinjes are firing, and Purkinjes are hitting the cells next to them. We're hitting the cells next to them. So it's via those gap junctions from sodium. So sodium will open up, and myocyte to myocyte. So it takes a little bit longer for those ventricles to depolarize. And because of that, we're going to see these wide QRS complexes. So this top beat is a ventricular escape rhythm because we have PQRST all the way through until we have a pause. And when we have that pause, the body's trying to figure out, okay, who's going to take over this pacemaker responsibility? And ultimately, we can see that the ventricles took over. We know P wave that we can see. Actually, there probably is a P down here, but we don't see it before the QRS. And we have a wide QRS, wide QRS, wide QRS. Remember, our QRS is from the beginning of the Q here, or the R as it goes up, all the way until S comes back to our baseline. So here we also have wide QRS, and these, again, we're getting some sort of retrograde depolarization because the ventricles are trying so hard that here we go, we got a little P wave here, a little P wave. We don't see anything before the QRS, we don't see anything inverted. We've got this wide QRS complex where junctional is going to be narrow without a P wave or an inverted P wave in front of it. These patients are a lot more likely to be symptomatic because the heart rate from the ventricles is going to be 20 to 40. Okay, especially if they're used to heart rates, even 50, 60 on up. If they've got a heart rate of 20 to 40, these patients oftentimes will have pre-syncope or syncopized or might be lightheaded, especially when they go to stand up. Okay, so again, this is a ventricular escape rhythm because we have P, we have our QRS. We don't have much of a T, but we do have a P, QRS, and then something happens. You got an abnormal beat here, and then we go into our escape rhythm here. Okay, and again, this is wide. We go up here, our Q, R, and we come down here, and our T comes back. This is kind of our T here. We come up here, so this is a little bit wide, maybe about 3 boxes, and wide, and then our rate as well. So this is an escape rhythm. And again, last is our atrial escape. Again, atrial escape often does not cause a bradycardia, but I want you to have it in thought of when you're talking about escape rhythms, that sometimes if the SA node doesn't pace, then the primary responsibility is for the atria to start pacing. Somewhere in the atria, it's usually one focus in the atria that will start pacing. So you may see that normal rate and rhythm where you have your PQRST, and then you've got a pause. And that pause is just long enough for the body to realize something else needs to pace, and then the atria can start pacing. And sometimes it's really hard to determine if this is an atrial escape rhythm because we still have a PQRST. But if you look at the P waves, they look a little different in morphology than the other P waves. Okay, so we know that we have a slight delay in depolarization here, because otherwise if this was regular, we go here, and we have another depolarization rate about right here. Because we didn't have that, something else is picking up, happens with the atria, and we know that because we have an upright P, it just sort of looks a little bit different than these P's over here. Right for this, 60 to 80. And for studying purposes, I don't typically have an ECG on the test for an atrial escape rhythm, or even an atrial rhythm, because it's too difficult to determine. If you just had, so if we come back here, and you did not have this first part, you only had this, I would not expect you guys to be able to say, oh, that's an atrial escape rhythm. I think it would be really hard for anybody to determine, is that normal sinus, because we have our PQRST, or is that an atrial rhythm that's coming a little bit lower? Okay, so that's it for our escape. Our escape beats or escape rhythms are going to occur later than we expect. So if you march out your R to Rs, you're like, wait, that looks a little bit irregular. I'm marching out, wait, this is occurring later. Why is that? That's some sort of escape. Something has escaped out because of overdrive suppression, or the SA node, or the atrial, or junctional. Okay, something up there did not fire, so the next area fired in response to that. Okay. Next we'll talk about is our AV blocks. So we got 4 AV blocks we're going to talk about. And we say atrioventricular, that means at the AV node area, there's something not quite right, and it's blocking then the depolarization, at least partially blocking depolarization from the atria down to the ventricle. We have first degree, we have second degree, which is a Mobitz 1, okay? And then we have a second degree Mobitz 2, and then we have third degree AV block. Okay, so first degree can be a normal variant. It could be from electrolyte derangements, it could be from hypothyroid, it could be from medications we're giving the patient. Second degree Winkelbach could be from meds, could be from some sort of ischemia, myocarditis, or even an inferior MI. Second degree Mobitz type 2. Now, second degree Mobitz type 2 is much more concerning than second degree Mobitz 1 or that Winkelbach. Second degree Mobitz 2 is concerning, and then third degree is very, very concerning. So Mobitz 2 could be from an MI as well. Third degree from an MI. Cocaine is a big common because of third degree AV block, or medications like digoxin or digoxin toxicity can cause that. So our first degree AV block. In our first degree AV block, we have our P, we have our QRS, and we have our T. Okay, but the problem in our first degree block is the PR interval. The PR interval. So our P is upright, our QRS is normal, so less than 3 boxes. Our T is upright, asymmetric, but our PR interval is long. What is our normal PR interval? 3 to 5 small boxes, or 0.12 to 0.20. So we're talking about greater than or longer than those one big box or 5 small boxes. Consistently, every PR interval you measure on that ECG, down at the bottom of that strip, is going to be consistently long. Okay, so this one is 6 boxes, the next one is 6 boxes, the next one is 6 boxes. Not 6 boxes, then 7, then 8, then 9. It's consistently 6 boxes, okay, or 7 boxes, or 8 boxes. It doesn't get longer and longer and longer and longer. Okay, does that make sense? Again, these patients, so in the military setting, for these patients, if you have an ECG, they have first-degree heart block on it, it would be nothing wrong with sending them to cardiology for evaluation. Otherwise, there's really not much to do. They've already been evaluated, they haven't had a prior ECG, they're completely asymptomatic, there's really nothing else to do about this. Some people are really sensitive to this prolonged PR interval, and if they're having a lot of symptoms, then they'll ultimately put a pacemaker in them for these patients. But we're looking at that PR interval. Remember, PR interval is the beginning of the P to the beginning of your QRS complex. Your PR interval should not be greater than 1 big box or 5 small boxes. If it is, it's considered prolonged, and it's going to be consistently prolonged in our first-degree AV1. So here, this is right about, from our beginning of our P here to our QRS complex are about 6 boxes. The same thing here. So you measure that out with your calipers. If it's not directly on a line, measure your calipers and then take your calipers and put them on a dark black line so you can count your boxes. Or you just count your boxes in between. 1, 2, 3, 4, 5, 6. Here we have evidence of a first-degree AV block. Now, sometimes this PR interval is so long, it butts right up to that T wave. And you're like, wait, what in the world? That looks crazy. That looks like a U wave. But then as you look closer to your QRS complex, but I don't have a P wave there. That's actually your P wave that's right next to your T wave. So these guys have super long PR intervals. Okay. Consistently greater than 0.20 every single cycle. Every single cycle. So that's it for our first degree. Our second degree, Mobitz 1, our Winky Bach. Okay. Here, our PR intervals could be start off normal, but then they get longer, and then longer, and then longer, and longer, to the point then we have a P with no QRS complex. We have a longer drop, must be a Winky Bach. So our PR interval is longer, and then we have a P, but we have a dropped QRS complex. We do not get any depolarization down to the ventricles, and then the body resets and starts over, and we have the same problem. We have a PR interval that may look okay. The next one is a little bit longer, may look longer. So it doesn't have to be greater than 5 small boxes at all, but it's not consistent. Normally, PR intervals should be the same. Here, they're getting longer for every single beat. And so we have a PR interval here, and this looks very normal. We got a P, QRS, don't really see much of a T here, but that's okay. But this is a very normal PR interval. The problem is, as we come to our next PR interval, we can tell that our P is way over here. This one's right next to the Q. So that is longer, so normal, longer, and then we have a P wave with a dropped QRS complex. And like I said, this one here, you don't see much of a T wave at all, not much of a T wave. But you have P, no QRS complex. Here we have P, QRS, we have a P, okay, and we don't, and our QRS complex is here, then we have P wave with no QRS complex after. Same thing down here. PR interval initially looks okay, but it gets a little bit longer, and then we have a dropped QRS complex. P, QRST, P, but it's a little bit longer PR interval, QRST, and then a P wave with a drop. When we're looking at our rhythm, we always say, do our QRSs have a P before them? Do our P waves have a QRS after them? If they don't, something is causing a block from the atria down to the ventricles, and it's going to be a P wave where the atria are depolarizing, but the ventricles are not depolarizing. Again, so we think about longer drop, must be a Winky Bach. Now that doesn't mean every single time it's PR interval, and the next one in prolonged, the next one, and then it drops. Not every fourth beat. That's just the same. Longer drop must be a Winky Bach. All right, the next one is here's another picture of our Winky Bach. So we've got our PR interval here, the P, QRS. Here's our good T. Okay, you can see, now it may be a little bit hard to see here, but that's why you get your calipers out and you measure from P here. And then you can see this one's a little bit longer. This one's a little bit longer. This one's longer, and now we have a P wave without a QRS complex. After that, the body says, well, wait, let's reset. It resets and goes back. We got our P, QRS, T, okay? We got our P, QRS, T, but our PR intervals are once again, they kind of prolonging, and then we have another drop on our QRS complexes, okay? That's our winky bot. Longer drop, must be a winky bot. Okay, our second degree antibiotic moments 2, more concerning than a winky bot. Here, our PR intervals are normal. PR intervals are normal, but we have P waves with no QRS. Just spontaneously out of the blue, we have P waves with no QRSs. The problem with this one is you might have 3 or 4 atrial depolarizations before you get another ventricular depolarization. So these guys' heart rate might be 20 or 30, depending on how many times that block occurs. Okay, so here we have a PQRST, we have a P without a QRS. Okay, we have PQRST, P without a QRS. But here we have, here's a P wave, here's a P wave, so now we're missing 2 cycles. We have only atrial depolarization with no ventricular depolarization. Imagine if you had a PQRST with a P wave with a QRS drop, QRS drop, QRS drop, QRS drop, and then finally you get a QRS. We have really minimal circulation going out to the body, right? So PR intervals are normal, but you have spontaneously dropped QRS complex. You have P's without QRS complexes. And so this is a Mobitz 2 here. We have a P QRS T, and then we have a P wave without a QRS complex. P QRS, not much of a T, P QRS, P QRS. Okay, then again we have a P wave without a QRS complex. We come over here, we have a P. So I know sometimes you might think, well, how would I know if that's a U wave or not? We've got to figure that out, right? That's what we call clinical presentation. How is this patient presenting? Maybe we got to get labs on them, okay? But we should have, if we have U waves, it's not going to be every now and then. U waves are going to be there and be consistent, okay? Between every T and P is a U wave. They're not going to just come every now and then, because the mechanism of that is usually electrolyte derangements, and electrolyte derangement is not changing every beat of the heart. Our last block is our third degree block, and this tends to be quite a bit harder for people to conceptualize. In third degree block, okay, we have a total lack of conduction from the SA node to the ventricles. But the atria, the SA node is working, the SA node is firing, the atria are depolarizing. The ventricles don't get that depolarization, so the ventricle says, hey, I didn't get word that depolarization was occurring, so I'm going to depolarize as well. So at the AV node area, at that junction area, there's no coordination, no depolarization at all going down to the ventricles. So atria, they're doing their job, they're firing. Ventricles is waiting, like, wait, I don't get anything, so I'm going to fire too. So now we've got this. We've got this asynchronous firing of the atria. But the atria is firing on point. Okay, they're still at 60 to 100. Ventricles, they're firing on point. They're doing their 20 to 40, but they're not talking to each other at all. So what you're going to see P waves, and you're going to see QRS complexes, but they're not associated with each other. You may see 1 or 2 P waves right next to the QRS complex. It's by happenstance. It just happened to land that way. If you march out the P waves, they're going to be regular. And they're going to be that 60 to 100 beats per minute. If you march out those QRS complexes, they're going to be regular, but they're not talking to each other. Okay? These patients oftentimes are going to be symptomatic, syncope, pre-syncope, dizzy, lightheaded, because their rate is so incredibly slow. We've got a little picture here. Again, this P wave looks like it's directly correlated with that QRS complex. It just happened to land there. It's not because it's talking to the ventricle, it's because they're not. So we've got a P wave here, we've got a P wave here, so these P waves are marching out. If you took your calipers, you mark here or your piece of paper, put a tick mark here and a tick mark here on your piece of paper. Move those same tick marks here, move them here, and you can see a P wave in here, move them here. Those P waves are marching out. They are regular from P wave to P wave to P wave. Okay, our QRS complex, we have Q here, 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 here. If you just look at those QRS complexes, what do they look like? Okay, regular rhythms. Okay, they look regular because the ventricles are doing their job. They're pushing out this regular pacemaker responsibility, okay, but they don't know that the atria are also firing. So they're working independent of each other. So here we have a P wave. We have a P wave here. Okay? Once you identify two P waves, okay, and sometimes you can do it at the beginning, sometimes you have to come to the middle of your strip. Take your piece of paper.
Bless you.
Take your piece of paper, put a mark on one P and put a mark on the other P. And then march this along your rhythm strip. Okay? And you should see that those P waves line up. And because sometimes you won't be able to see what the P wave would be. Like right here's a P wave. But it's inside that QRS complex. I only know that that's there because I'm marching these P waves out. There has to be a P wave there because the atria are depolarizing. Okay, then there's another P wave here, another P wave here. These are marching out. Okay, and then look at our ventricles. We have a QRS complex here, 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 here. Again, if you were to measure those with your calipers or piece of paper, you'll tell if you put a tick mark on top of one R wave, tick mark the R wave, and you go to the next one, they march out exactly, because they are depolarizing. The ventricles are depolarizing like they're supposed to. They just don't know that atria are depolarizing. So this is complete lack of communication between the atria and the ventricles. The ventricular rate is going to be very, very slow. The atria don't provide much as far as circulation to the body. So even though the atria are doing their job, the rate is so slow, these patients are going to be very symptomatic. Yes, sir?
How do you know that it's a two P waves and not a P wave and a T wave following? Or sorry, a T wave and a P wave following the QRS complex?
This is probably a T wave with a P wave inside here.
Okay.
It doesn't matter though. I mean, because the T wave, we like to see it because it just gives us, like, yeah, this is definitely normal science, but if you don't see a T wave, it doesn't necessarily mean anything, especially in the setting of a third-degree block. You know the heart is not functioning. It's probably not repolarizing it well because it can't, there's a block between, even for repolarization appropriately. Okay? So the atria are repolarizing by themselves, but the whole AV here is not. So you're probably not going to see much of a T wave. Okay, so PR for our first degree AV block, PR interval is consistently prolonged every single beat. It's longer than the 3 small boxes or 5 small boxes. Okay. For our winky block, our Mobitz 2 or Mobitz 1, or winky block, the PR interval gets longer and longer and longer and longer until you have a dropped QRS complex with a P wave. So P wave standing alone, no QRS complex. In our Mobitz 2, the PR intervals are consistent, but we occasionally have these drop P waves. And then in our third degree block, P wave, the atria are firing, the ventricles are firing, but they're not talking to each other, so you can see independent rhythms on your ECG. These patients typically come in after they syncopize because of their rate is so low. All right, let's take a break, and then we'll talk about some other arrhythmias. We'll go over a whole host of other arrhythmias you may see on your ECG. The first one is a sinus block. So sinus block is merely the ECG is missing a complete cardiac cycle. So unlike an AV block, where we have the P wave, maybe not a QRS, here there's no P, there's no QRS, there's no T. A complete cardiac cycle is missing, one of them, only one, and then the body says, oh wait, let me do my job. Heart goes back and it starts pacing a normal. Or an ectopic rhythm might come into play, okay? But you're missing one complete cardiac cycle, there's a pause. So if you were to measure from R to R, okay, we should have an R wave about here, it's missing, so that whole cycle is missing, and then we go to the next. So okay, so if we wanted to cut, if you're like, well, I only have 2 here, so you come back here. R, take that piece of paper where you put your little tick marks, move it over here, and you can see, oh wait, I'm supposed to have a QRS complex here. I don't have one, but this lines up and this lines up. That is a sinus block. missing one complete cardiac cycle. Okay, the SA node is not pacing for some reason. Okay, so we've got this prolonged period between one QRS complex and the next. And then again, we pick right back up, usually with the SA node, occasionally giving some sort of ectopic rhythm as well, from the atrial or the junctional or the ventricles. Most of the time, these patients are asymptomatic, there's nothing to do, but if they have this every 3 or 4 beats, they're going to become symptomatic, right? And if that's the case, oftentimes they need a pacemaker. The SA node, something's going on with the SA node, since it's blocking it, permeability to sodium has changed something, and so they'll look at medications to see if that's the problem, and ultimately they may need a pacemaker. Sinus block and ECG, again, we're missing one complete cardiac cycle. If we march these out from here to here, a piece of paper, and then move those tick marks over here and move it here, we should have a cardiac cycle here, but we don't. And then we're also missing one over here. So again, if they're having these frequently, they're going to typically come in, they might be symptomatic, and those patients need a cardiology referral. If sinus arrest, would be that unhealthy SA node, again, fails to fire, but we have at least 2 complete cardiac cycles that are missing in a row, at least 2. So SA block is 1, that's 2 or more cardiac cycles that are missing. This could be from some sort of coronary artery disease, maybe the person registered an MI. Again, if that right coronary artery is involved, it'll affect the SA node. It could be a younger person that had cardiomyopathy. Okay, a lot of times cardiomyopathy in young folks can be caused by a virus. And so those patients may come in with frequent episodes of sinus arrest as well. And here we have our PQRST, good. And then if we march these out, we should have something here. Okay, we should have something here. So we're missing at least 2 complete cycles in between here. And then we start again, a little bit of an abnormal beat here, but then we've got our PQRST. What does this look like to you guys? Maybe like a, probably more like a junctional, because you start here and you measure to here. Okay, so it might be, but it's very narrow. So usually when we think about ventricle, that QRS complex is going to be pretty darn wide. Here, that QRS is fairly narrow for your R wave. But we definitely don't have this. It definitely doesn't look like coming from the SA node to the atria, because we don't have our P to fire. But then it looks like our SA node starts to fire again. Okay, so we look at this. What do we think this is? Do we think this is a sinus block or sinus arrest? Probably a sinus block, right? We look like we're missing 1 complete cardiac cycle. It should be about right here. So this would be considered a sinus block. Again, not necessarily something to do, but certainly want to look at the patient's medications. Look, sometimes even something like a urine drug screen to make sure that's not the case. I don't see that much in the military, but definitely for the National Guard and Reserve folks. Look at their diet, look at their intake of sodium as well. For people that have these persistent sinus blocks or these sinus arrests, right, where the SA node is indicating that it is not functioning well, sometimes these patients will have something called sick sinus syndrome. Sick sinus syndrome. And here, again, the SA node is really giving out. We see this a lot more often in much older folks, but certainly some younger folks can have it as well, depending on their underlying disease process. Okay, but what we'll see episodes of tachycardia and bradycardia, we'll see sinus blocks, we'll see sinus arrest, all of those intermixed on one ECG. So here we have a couple of beats, and then we have, probably a sinus arrest here. Okay, maybe a sinus block in between these two, a little bit of bradycardia, and we go tachycardia. This is actually one rhythm strip. So if you were to cut these in 3 and you place them all along here, this is one person's heart over a couple of minutes. Okay? So you can see they're a little tachycardic, okay? And then they have this long sinus arrest. And then they go back into tachycardia and a little bit decrease in heart rate, and then they've got this sinus arrest, and then tachycardia. So we call this a Brady syndrome. You might hear it called nowadays as well. But we used to call it sick sinus syndrome, and these patients they need a pacemaker. They cannot go home. If you have anybody's ECG that looks like this, is bad. That sinus node is really trying to die on you. And the problem is we have other parts of the heart that can take over pacemaker function, but not for the rest of their life. We need something that's going to pace them normally for the rest of their life. And so those patients will be admitted and they'll get a pacemaker. We can have something called sinus arrhythmia. Sinus arrhythmia. And although the word arrhythmia, we've come to know it seems like it's significantly abnormal, like maybe it's something that we really need to act on. But sinus arrhythmia is a specific abnormality where the rate looks slightly irregular, but it is in association with the patient's breathing. When you inhale, it activates the sympathetic system, so your heart rate might increase for a beat, might get a little bit closer. Right? When you exhale, it's the parasympathetic system, so it slows down just a little bit. So the change that you're going to see from R to R might be a half a box, it might be 1 box of a change. So it's very, very subtle. And when you see it on the top, oftentimes it'll say sinus arrhythmia. If you see it, what you're going to do is put your hand on the patient's pulse and watch the patient breathe. And you'll feel the change in their pulse when they take a deep breath in, when they take a breath in, and they breathe out. It doesn't have to be a deep breath, just normal breathing, and the body, that'll be captured on their ECG. There's nothing to do about it. Some people just have really sensitive, like I told you, they're really sensitive to their vagus nerve, and so that will change their heart rate slightly when they inhale and exhale. Nothing at all to do about it. So here on this ECG, again, it might be a little bit hard to see, but you can tell from this R wave to this R wave, there's a difference in length, right, or width between those two, and this one, or this one. If you put your paper on here, put a little tick mark here, a little tick mark here, you can tell that this really should be about here somewhere. So this is an association with, if it's a little bit longer, that's associated probably with them exhaling. Okay? And here we have the same thing. We can see a little bit longer here, but that's normal, a little bit longer. This is inhalation and exhalation. Exhalation here. Inspiration. Okay. So this is a sinus arrhythmia. Okay, we're going to look at our lead 2. We got an upright P. We're going to look at our ADR. We've got a downgoing P. We got a QRST. So we know this is coming from the SA node. And then we can see this looks pretty regular. Then we've got a little bit of a pause here. Okay, and that's your exhalation. And we go back to regular. So if this is a 10-second strip, how many times do we typically breathe per minute? 12 to 20. So in a 10-second strip, you oftentimes will see it once. Okay? Unless someone is breathing a little bit faster, you may see it a couple of times, but typically we'll see it 1 time. And that's why I say, when I see it, I just kind of look at the patient breathe. Usually they're on a monitor, and I just kind of correlate the breathing with the monitor, or I'll feel their pulse. And I can feel it on their pulse when they inhale and the exhale. It's like nothing to do about it. We have something called the wandering atrial pacemaker. Here, these patients have a regular rate, a rate of less than 100, and then our rhythm is irregular. We've got a slight change between our R to R. Okay? What we have going on when we look at our P waves, we have P waves that are of different morphology, at least 3 or different morphology P waves. Usually due to something like respiratory disease, like COPD. It could also be due to valvular disorder, increased vagal tone. What does this sound like to you guys? Matt. This is Matt in a slow version. This is a slow version of Matt. Okay, so if it's greater than 100 rate, we call it multifocal atrial tachycardia. If it's less than 100, we call it wandering atrial pacemaker. The treatment is the same, which is not treating the ECG, but treating the patient. Control their underlying respiratory problems, hey, if that's the issue, or whatever their underlying issue is, and that will fix their ECG. There's nothing else to do. Most of the time, again, these patients are asymptomatic. They're coming in for their underlying disease process, and we happen to see this on the ECG. But we have 3 different morphologies. We got a P wave here. We've got an inverted P here. We've got a P here and here. It's an irregular rhythm, okay, but our rate's gonna be less than 100. And this is evidence of a wandering atrial pacemaker, so our rate here is about 96. Remember, for when we have an irregular rhythm, we came down to the counting that, so we've got to count our R waves that are crossed here. And then if we look between this R wave, or I guess it's S wave, okay, this S wave, okay, we have a difference. It's irregular, and then our P waves, we're going to look at those. And our P waves look a little bit different. Here it's flat P wave, more upright. Here we have an inverted P wave. So three or more different morphology P waves. And that's because it's coming, where is this depolarization coming from? SA node? Atria. Coming from the atria, somewhere in the atria. Matter of fact, 3 different areas in the atria. Because if it was the same foci in the atria, it would have the same looking P waves. So three or more different foci in the atria are firing, which is causing these abnormal P waves. So for some reason, the SA node did not fire, and now the atria are taking over pacemaker responsibilities. And we talked about ectopic beats, or ectopic rhythms. Okay? Ectopic means that we've got a delay, and whatever that next beat is going to be, it's occurring later than what we'd expect, whether it's a rhythm or a beat. We can also have what we call premature beats. They're occurring earlier than what we expect. It can be atrial, it could be junctional, or it could be ventricular premature beats. Okay? So a premature beat, okay, is usually 1 or 2 beats. If you have 3 or more premature beats, that's going to be now called a rhythm. It's going to change the rhythm of the CCG. Okay? So what can cause this patient to have premature contractions? Well, it could be just from increase in the sympathetic system, it could be from the parasympathetic system, it could be from caffeine, it could be from medications, could be from hypoxia, could be from thyroid problems, a whole host of issues that can cause these premature beats. And a lot of times there's nothing to do about them. Okay? They occur occasionally. If someone comes in with PVCs, premature ventricular contractions, okay, and if they're frequent, it's usually because they're taking a lot or drinking a lot of energy drinks or taking like pills or something like that that's causing it. So you've got to look at their diet, you've got to look at their exercise, you've got to look at their caffeine intake, because oftentimes, especially in the military setting, that's usually what it's associated with for these premature contractions. Okay? If we have a premature atrial contraction, okay, so think about premature atrial contraction. Is it going to have a P wave or no?
Yes.
Yes, because it's coming from the atria. It's just coming earlier. So the SA node fires, and then there's an irritable foci within the atria somewhere, and that is firing as well. So the SA node fires, we look like we have a normal PQRST, 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 and then that foci in the atria, for some reason, it's going to fire as well. It did not get the impulse, okay, so it's going to fire because it's irritable. And the reason is if you remember, why is the SA node the primary pacemaker? Because it's most permeable to sodium. Okay, for some reason, this foci has become more permeable for 1 beat, and then the SA node takes back firing again. So you're going to tell that it's premature, it's earlier, occurring earlier than expected, and the P wave is going to look different than the other P waves that are coming from the SA node. Okay, so here we have a PQRST, let's pan out, but look at this one. Okay, so if we were to measure from here to here, and here to here, okay, this is occurring a little bit earlier than here to here. So, you know what I'm saying? So if you take your piece of paper and you measure R to R, and then measure this next R to R, you can see that that's occurring a little bit earlier, this beat, and then we go back to our normal sinus rhythm, normal sinus rhythm, normal sinus rhythm. This just occur a little bit earlier, and then the P wave's a little bit different. Not much different on that one. Okay, premature atrial contraction, or you may also hear a premature atrial beat. Here's a couple of them. Okay, so we've got, it's hard to tell on this one because this one's early, but we'll do a PQRST, PQRST. That's a pretty good, this looks pretty regular, but we have something here that has occurred earlier, So it's premature. Actually, we have a P wave, but does that P wave look like these other P waves? No, and it's not inverted. So that tells you that's a premature atrial contraction because it's an upright P that looks different from your sinus P. And then we go back to our sinus rhythm. And again, if you look from here to here, you can tell this is a little bit longer, but if you were to march these out, put your tick mark here, your tick mark here, march it out, this right here is falling right in line with where it should be. Normally this would be right over here, and then this is falling right in line as the SA node resumes pacing for this patient. We've got another picture up here. We've got a PQRST, PQRST, PQRST. We've got a complex that is occurring earlier than normal. We've got a P wave associated with it, okay? But it looks a little bit different, more peaked P wave than we see here, and that is considered a premature atrial contraction. Usually not much to do about those. They occur sporadically, there's not a lot to do about them. Just ask your patient, figure out what their diet and exercise routine is, and see if there's anything you can adjust there. And most of the time, patients don't even know they're having them. Sometimes they may come in complaining a little bit of palpitations, but usually because the atria doesn't take a lot of electrical conduction to depolarize it, most patients don't even know that they have it. Okay? We have premature junctional contraction. Okay? The junctional contraction, is that going to have a P wave or no? Maybe. What might that P wave look like?
Inverted.
Inverted. Okay, so it might have a P wave, but it's not going to be upright. It typically is going to be inverted. Narrow complex. Okay, it's going to occur earlier than normal. So here we have a P, and we have our QRST. We have a P here, QRS. We have a P here, and then we have a premature beat. Okay. And if you look at these other ones, you can see your T kind of comes up here like this. So your T is coming up. So I know that that looks like a P, but it looks exactly like this T wave. It comes up here. So really you have a little bit of an inverted P right here with a narrow complex QRS, and then we go back to our baseline. Okay, we also have another premature beat here, and you can see this one does not have a P wave that's associated, not even inverted, and this is a junctional, premature junctional contraction. All right, so we have here, okay, this is very low amplitude in our QRS. We do see that very low amplitude in our QRS. Okay, but then we have these tall waves that occur right here. And tall waves that occur here, they're occurring just a little bit earlier than we would expect if we measured out. If we measured it out, it should occur about right here. But these are occurring a little bit earlier. They have no P that's in front of it, it's highly inverted, and we go back down to our normal PQRS, PQRS. These are two junctional, premature junctional contractions occurring earlier in the cycle than what we would think. And junctional contractions are actually pretty rare. We don't see a lot of junctional contractions. More commonly, you'll see ventricular contractions, PVCs. PVCs. You will see atrial, occasionally junctional, PVCs, and most of the time these patients are symptomatic because of the nature of the ventricles and the amount of electrical conduction that is occurring. Okay, so PVCs are these big, wide, ugly QRS complexes. They're occurring earlier than what we expect, and they're very, very wide because now the ventricles are not depolarizing via the electrical conduction pathway. For this, we have a foci in the ventricles that is irritable, and it's myocyte to myocyte specifically for that contraction. The rest of it's okay. The rest is coming from the SA node. So we have SA node firing here, SA node firing here. Then we have this premature contraction that is wide and ugly. Okay, it comes from here all the way down here, back up to our baseline. So greater than 3 boxes for sure. And these patients usually will feel palpitations as associated with this. Now again, think about medications, and a lot of times this is increase a lot of caffeine in these patients. Some of you guys probably have these, for sure. Okay, so we look at our rhythm strip here. So again, when you're looking at these ECGs, it's really easy to get distracted and look at the whole ECG. When you first look at it, just take your eyes down, look at your rhythm strip. That's just gonna tell us the majority of the things we need to know on these patients. We're gonna look at this rhythm strip. I can see I got a pretty regular rhythm. My rate doesn't look to be super fast or super slow. Okay, but I can see that this really stands out when I'm looking at this rhythm. So I'm like, wow, what the heck is that? Well, remember with these ventricular contractions, you may still have P waves that are in there, but we don't see a P wave specifically before, but we see this big, wide QRS complex. A big, wide QRS complex is going to be a PVC every single time. PVC, ventricular contraction. Okay. Here we have PVCs, but we have many PVCs. What does that remind you of? VTAC. VTAC. We talked a couple days ago about sustained versus non-sustained VTAC. It's less than 30 seconds. It's not about the amount of beats, but less than 30 seconds is non-sustained. Greater than 30 seconds is sustained. And if you have sustained VTAC, okay, then you want to treat it as if it's VTAC. You want to give these guys some medication, like an EMNO or something. Okay. So, but we started off okay. We had a normal PQRSTs, a normal sinus rhythm here, and then we have this run of VTAC, and then, man, the heart goes right back as if it never even happened from the SA node fire, PQRST, PQRST. Okay, here we've got several run of VTAC here as well. Okay, so this is 6 PVCs in a row. That would be concerning. So we've got 3 PVCs here, we've got 1 here. So that's that really wide QRS complex. We talked about something called torsades. We talked about it a couple of times. We talked about as well an absolute and that relative refractory period. Well, that relative refractory period leads to this R on T phenomenon. If you get an insult like a premature ventricular contraction, and it occurs on the downsloping part of that T wave with a relative refractory time period, it can put these patients into that fatal rhythm, that torsade. So we might get super lucky and the body brings them back out and goes right back into a sinus rhythm. Okay? Or we might get very unlucky and it doesn't. But when that PVC occurs on the down portion of that T wave and that relative refractory period, that PVC is enough to cause depolarization to occur prematurely. So the depolarization and the repolarization kind of run into each other, they cross each other out, and now we get to go into this fatal arrhythmia like this torsades. Okay? And torsades we talked about specifically occurring with people that have like a prolonged QT or hypomag or hypo-K. Okay, but it can occur in people that have frequent PVCs as well, which is why for premature ventricular contractions, we take that a little bit more serious. And we want to talk to our patients and figure out if we can identify a cause. And if we can't, they're having these frequently, then they may need to see cardiology. And you can have things like bigeminy or trigeminy, where you're having frequent PVC. So bigeminy is you have a normal QRS complex that's coming from the SA node, and the very next beat is a PVC. And then you have a normal coming from the SA node, and the very next beat is a PVC. So each normal beat is coupled with a PVC. That's frequent PVCs. These patients are at risk for the RIT phenomenon, at risk for going into a torsade or fatal rhythm. Okay. If you have trigeminy, you have 2 normal beats, and then that third beat is coupled on is a PVC. So it's still concerning, but not as concerning as bigeminy. So if you see someone with bigeminy or trigeminy, it doesn't necessarily it doesn't mean a phone call to the cardiologist, but it certainly requires probably a profile of not having these patients do a bunch of sports or activity, and probably a consult or referral to cardiology. Okay? Especially if it's you have a prior history or a prior ECG and there's no history of it, you've got to think about maybe doing labs on these patients and evaluating what their intake is. And I know we're in the military and we like to think that people don't do cocaine. You know who does a lot of cocaine in the military? Riggers. Riggers that rig the parachutes. Oh my God, I've never chaptered so many people in my life, but they're riggers. Because when they come in, they have to sign up for a minimum of 6 years. And by half a year, they hate their job so much, they got to do anything to get out. So those riggers, they do a lot of cocaine. If you go to Fort Bragg, first of all, be careful you're shooting. And second of all, see, right? True, they do a lot of things. They're coming in my gym, you're like, I already know. Okay. Just like we talked about the escape rhythm, it could be a rhythm, 3 or more beats, or it could just be an escape beat. Okay, we got an atrial escape beat, we have a junctional escape beat, we have a ventricular escape beat. Atrial escape beat is going to occur later than what we think, okay? And it's going to have a P wave. This is like a sinus arrest. We're going to have a P wave, but that P wave is going to look a little different in the morphology. Junctional, it's going to occur later than what we expect, either inverted P or no P at all. Okay, and ventricular, later than we expect, no P, although the P wave for this one is right down here. You guys can see a little change here. Wide QRS, wide and ugly QRS complex. Hit you in the face, you can see that. If you looked at nothing else and you look at this, you're like, whoa, that is really wide. The rest of these don't really stand out, but that ventricular contraction is going to stand out. So how do we determine if this is an escape beat versus a premature? Escape is going to occur later than what we think. So I'm going to take my piece of paper, I'm going to put my little tick marks on my first set of RR, and I'm going to move my paper along and see if it's occurring later than expected. Premature occurs earlier than expected. Okay, and then you've got your atrial, your junctional, your ventricular premature, or escape beats. We have something called pre-excitation syndromes. Okay, there's 2 primary pre-excitation syndromes that we talk about are Wolff-Parkinson-White. Okay, when we talk about long gain on Levine. Wolff-Parkinson-White is much more common than long gain on Levine. There's some people that would say is long gain on Levine a real thing, but I think the latest literature says, yeah, it really is. It's an accessory pathway to large abnormal conduction of the depolarization directly down to past the AV node and then down to the ventricles. Okay? So Wolff-Parkinson-White, there's an accessory pathway that connects the atria to the ventricles. It could be on the left side or it could be on the right side. If it is associated with tachycardia, we call that AVRT. AVRT, remember, that's considered our SVT. Okay, so we have AVRT, we have AVNRT. Which one is more common? AVNRT. Because AVRT, Wolff-Parkinson-White, is not all that common in general. But again, if it's associated with a tachycardia, we get a lot more concern because these patients can have really high rates in the 200 to 300, mid-300s even. Okay? And then low gain on Levine, it's an accessory pathway of the internodal pathway. So internodal pathways are what take the conduction from the AV node down to the SA node down to the AV node. And here, this comes off of that and it bypasses the AV node. And the conduction goes right down to the ventricles, which is probably not a big deal as long as the SA node is firing appropriately. But it's a big deal if the atria, like you have atrial fibrillation, right? And every one of those atrial depolarizations get down to the ventricles. It's a big deal. Okay, so Wolff-Parkinson-White, typically a congenital disorder that we see in patients, 20 to 35-ish. And here again, there's that accessory pathway that is allowing electrical conduction that goes directly down to the ventricles, or can come up or down through the AV node and back up around through this accessory pathway and right back through the AV node. So the AV node is still functioning, okay, but it's depolarizing the AV node a little bit quicker than normal. But what we're going to see on our ECG, we'll see a P wave. And our QRS complex is going to look a little bit different. Instead of our wave going directly up, and straight down, it looks a little bit concave. Sometimes it'll look convex, it'll come out like this, but a lot of times it looks concave, but sometimes it even looks a little squiggly going up because of the abnormal depolarization of the ventricles. If we have a normal conduction pathway, the ventricles are going to depolarize very quickly, up and straight down. But here, that's not the case. So what we're going to see, we've got that depolarization, we've got the SA node that's going down to the AV node, and it's going down to the ventricles. Okay? But what else you see is some of those depolarizations can come down through that accessory pathway and come directly down through the accessory pathway. If that happens, okay, then what's going to happen is depending on which side the accessory pathway is on, it's going to depolarize that side of the ventricle a little bit earlier than the other ventricle will get depolarized. Okay? So we've got depolarization. This is happens to be on the right side, but it could be on the left side. Depolarization of that right ventricle is going to occur a little bit earlier than normal. And instead of having that straight up and straight down, that's what's going to cause that slight change in our R wave. It can have a convex or concave, or it can be a little bit squiggly up. So here we've got type A and type B. So if it's a type A is on the left side of the heart, okay, type B is right side pathway. So that little area of electrical conduction can be on the right side or the left side. So type A is going to be our left side. Okay, and here, the other thing that we know to look for is our PR interval. So both of these are going to have a short PR interval. Why do we have a short PR interval? Because some of that's going to bypass the AV node. The AV node is what gives us our PR interval. Okay, but now we have one side of the heart that's depolarizing a little bit earlier than the other side, so that PR interval is going to be a little bit shorter. So both have a short PR interval. Okay, both are going to have a little bit of a wider QRS complex. Okay. We've got a short PR interval, we've got a little bit of a wider QRS complex, okay, in both of these. In our type A, okay, look at this. You've got this really tall R waves here, these really tall R waves in our type A. Okay, the other thing we'll see in our type A, if we look at V1, V2, and V3, we've got these inverted T waves. Inverted T waves. We don't see that in our type B, our right sided pathway. In our right sided pathway, we've got our normal appearing S wave in V1, a little bit of an R wave, V2, a little bit of S wave, a little bit more R wave, V3. So it's normal appearing there. Here we've got these tall R waves with inverted T waves. Okay? So short PR, wide QRS, and then we've got this change here in our V1 through V3, where here it looks pretty normal. We've got our tall R waves over here. Okay? And then look at our T wave inversions are going to be on our other waves, our 4, 5, and 6, versus our 1, 2, and 3. And that's really your big difference, is those R waves are more prominent in V1, V2, V3 than they should be. So that's the first thing you look at. That's the first thing that should be your indication, like, wait, why are my R waves prominent in V1, V2, V3? Normally you have a very small R wave and a prominent S wave, but here we have the reverse of that. Okay, we're going to see that those PR intervals are shortened. And then we're going to look for a delta wave on here as well. Okay, so wide QRS, short PR, and then let me pull up this delta wave. So this, again, sometimes, now I had surgery, so one of my eyes sees far, and one of my eyes sees near. So once I can figure out which one sees which, and I pull out my magnifying glass, sometimes you have to do that to actually see these delta waves, because these delta waves may not be obvious. Okay, this gentleman over here pointed one out earlier, but you won't see that straight up and straight down, what you expect. You definitely will see an indication that why is my R wave not going straight up and straight down? Why is it more convex or concave, or why is it squiggly? Okay, so here you can see that coming up. Even without me blowing this up, you can see there's something a little bit out of place with these R waves, that they're coming up at kind of an angle instead of straight up and straight down. So those are your diagnostic criteria for WPW. Wide and QRS. We're going to have that short PR interval, and we're going to see that delta wave, usually in 20 to mid 30-year-old patients. Maybe they come in because they were lightheaded or dizzy, maybe a pre-syncopal episode, maybe they actually did syncopatize. Okay? Ask about a family history. Okay? Anybody, family history of any cardiac issues, anybody that had to have any cardiac surgeries, because they may have had WPW. Right. The other pre-excitation, so when we think about pre-excitation, again, is one of the ventricles are being excited prematurely. okay, is that lone gain on Levine. We've got our SA node, it's firing down to our AV node, but somewhere in these internodal tracks, we have an accessory bundle. So here we come down here, and this bundle of James, it comes off the internodal pathways, has its own accessory pathway that bypasses the AV node. So we no longer have the protection of the AV node. Again, if the atria are firing at 200 or 300, then this is when this comes into effect to be significant. Okay, now, every one of those can get down to the ventricles. We don't have the AV node that's our blocking. So these patients are a little bit different. They have a narrow QRS, still have the short PR interval, and there's no delta wave. So once we identify somebody that has a short PR interval, we've got to figure out why their PR interval is short. And we talked about that in our second lecture. Why is their PR interval short? Your differential should be WPW, should be LGL. Okay, those should be your two primary differentials for short PR interval. The other things they could have genetic short PR interval. Okay, could be still cause one of these, or it could be from electrolytes as well. But these must be in your differential for short PR interval. Again, for this, the QRS complex is going to be narrow and no delta wave. It's going straight up and straight down for LGL. Okay, one of the last things we'll talk about is Brugada. Okay, Brugada accounts for about 4% of sudden cardiac deaths. So this is really important. If we see the ECG abnormalities associated with Brugada, really important to get a family history. Do you have a brother, sister, aunt, uncle, cousin, mom, dad, grandma, anybody that died of sudden cardiac death? Because you have to think, back in the 1920s, 1930s, maybe even into the 1940s, when people died at 20 or 30 or 40, maybe not 20, but 30 or 40, what did they die of? Old age. That's how everybody died, old age. 30 years old, well, they died of old age. They were really stressed out when they died. Maybe not, maybe not. Okay? So we want to get a really good family history, and this can affect people from their 20s all the way up into their mid-60s for Brugada syndrome. Usually, though, you think about genetics. Okay, you can think about medications. Again, cocaine, the drug cocaine, could also cause it. We used to use cocaine for actually nosebleeds. Okay, so that could put these patients at risk. Okay. Oftentimes, these patients are asymptomatic. I caught this about 3 weeks ago on a psych patient. So when we have psych patients come into the emergency department, we have to medically clear them, and that includes labs, urinalysis, and ECG. And that patient completely asymptomatic, no history of anything, no family history, but he had Brugada syndrome. And so he went to cardiology and then to the psych. So oftentimes asymptomatic, again, they may come in, we might get lucky, they syncopize, they woke up, and then they came to see you. But often it's something associated with exercise. They were out exercising, they felt lightheaded or dizzy, or they passed out. So we never want to discard these patients who had some sort of pre-syncopal or syncopal episode while they were running. Because a lot of times we'll think about it as deconditioning, right? Well, look a little bit overweight, maybe your diet's not so good, that's probably why. But we want to have this in our differential as well. On ECG, we looked at leads V1, V2, and V3. Okay, we're going to look for a bundle branch block, which I know we haven't talked about that, but I'll show you what that looks like real quick, and then we do have a lecture on that. And then we'll look for something called these code ST segments. And so there's actually 3 types of Brugada, but we're going to focus on type 1 because type 1 is the only one that is specific that this is Brugada. The other 2 are suggestive of Brugada. So in type 1, we're looking for this, what we call RR prime. RR prime. Anytime you see an RR prime, that's indicative of right bundle branch block. An RR prime. And that means we have an R wave, we come down below baseline, we come back up above baseline. Okay? We have an R wave, we come down below baseline, we come back up above baseline. Okay? And that is your RR prime. You're going to have ST segment elevation. So you know we should be way down here at this baseline, right? Or our R wave takes us all the way back up here on this R. Okay, our S wave comes all the way back up here, second R. And then we have our ST segment. It's coved. It comes up and it comes all the way down and ends in this inverted T wave. And the T wave goes just below baseline. Okay, so R comes down to our S, comes back up here again, which tells us this kind of R prime. This is also ST segment elevation well above baseline. Then we come back down to our negative T wave. This in V1, V2, V3 is classic for Brugada. It is indicative of Brugada. These patients cannot go home without a cardiology telephone call and say, I've got a patient that has Brugada. When do you want me to have them come see me in the office? That's not that easy for active duty. So if active duty, if you identify somebody that has Brugada, you have a couple of options. I would certainly try to get a hold of a cardiologist so that you can have a phone call with them, because they don't like you to put in stat consults without a phone call. If you can't do that, there's no ER close by, okay, then you can put them in a profile, pretty much a dead man's profile. No physical activity until we can get you in to see cardiology. But it's usually, again, physical activity that pushes them into cardiac death. So V1, V2, V3 are going to be our leads for that. Alrighty, so this is evidence of Brugada type 1. So again, we're looking at V1, V2, V3. We've got our R that goes up, we come down, we've got our ST segment elevation, we go down to this cove ST segment, down into our inverted T wave. We've got a little bit of a cove here, we definitely have this ST segment elevation here. And that's always hard, right? Because we talk about ST segment elevation associated with myocardial infarction. So yeah, we do certainly have to think, is this person having sensitive MI? Okay, but the indications for MI are changes in other leads that are opposite to these leads, reciprocal changes, which we'll talk about in our MI lecture. So these patients won't have any reciprocal changes, and they're going to have this here, and we're going to talk to them about family history. The treatment for these guys, these need a defibrillator, implantable defibrillator, cardioverter. All right. Okay, so that is it for our lecture. Let's do a couple of skills checks. We got about 4 minutes, and we'll see how many of these we can get through. All right, what is our rhythm here? Do we think this is an atrial, a junctional, or ventricular?
Ventricular.
Anybody going atrial? Let's knock that out. No. Anybody going junctional? Junctional, why?
QRS is still pretty narrow.
Narrow QRS. We don't see a P wave. Narrow QRS. If we measure from here to here, less than 3 boxes. Narrow QRS. So this is going to be junctional. Junctional. And what is in red? What would we say that beat is? Is it occurring earlier or later? Occurs later. Wide or narrow? Wide. So? D, ventricular escape beat. Ventricular escape beat. And then we go back to our normal sinus rhythm. Okay, what about this one in red? Occurring earlier or later? Later. Wide or narrow? Narrow. P wave or no? None. So what do we have? Bravo. Junctional escape B, right? Junctional escape B. Okay. So if we look at this, and I will tell you that this, if we look at that rhythm strip, again, take your eyes, don't look at the entire ECG, just look at the rhythm strip. When you look at that rhythm strip, you're going to go through your same stuff. Look at the rate, right? I mean, look. 300, 150, 100, so it's less than 100. Okay, it looks pretty regular. A narrow complex. Okay, my QRSs, I got P's and QRSs and P's and QRSs. Next thing I go through is my PR interval. What do we think about that PR interval? Long. PR interval is long. So we call this a first degree AV block. Because you gotta look to see, is it consistently prolonged? You measure from the beginning of the P here to the beginning of the QRS here. And you take those same measurements, you move them over here, you move them over here, here, it's gonna be the same PR interval. Okay, so consistently so long, we got our first degree AB block. Okay, what about this one? Look at our PR interval here, PR interval here, PR interval here. And then we've got a P, but we have no QRS complex. What do we think is going on here? Charlie, second degree block, it's a winky bond. Longer, longer, longer drop must be a winky bond. So again, between here and here, it might be a little bit hard with the naked eye to determine that that's a little bit longer. And when we're looking at, but you can definitely tell from here to here there's a change. So take these and measure those out. Maybe these are the same, but you have this one, and this one's definitely longer, and then we have a drop. So this one, it's a little longer, but measure it out, and then you have a drop. So that's your drop QRS complex, but you have a P wave. So longer, longer, longer drop, that's going to be a winky bot. All right, last one. These two that have the arrows, what are those? Are they occurring earlier or later? Okay, wide or narrow, and P or no? Narrow, no P, what do we got? Junctional, premature junctional contraction. Okay, all right, that's it. Thank you so much.
Thank you, ma'am.
Again, I left those ECGs up there for you guys if you want to come.
We still have 3 more.
We're out of town.